Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director of Clinical Education and Partnerships at SICA, where we partner with healthcare providers to offer body composition solutions. And today I'm joined by Dr. Renee Rogers. She's a senior scientist at the University of Kansas Medical Center, and she's an exercise physiologist, obesity researcher. She's really kind of straddling that real world and research, and she's fantastic. So thank you for joining me.
Oh, thanks so much, Nina. I appreciate it. I'm really excited to be here.
Yeah, well, I know that you just got back from the ACSM, the American College of Sports Medicine annual meeting, where you did a featured symposium with Caroline Apovian, a big obesity medicine provider, and John Jakecic, who you worked closely with for a very long time.
Yeah.
So I wanted to have you kind of come on and talk to us about that. It's really a topic, sort of this exercise and obesity medications that you guys are really experts in. I love sort of seeing your real world commentary on it, but also knowing that it's backed in a behavioral science approach. And so I think you're the most exciting person for me to talk to about this topic.
Well, you're too kind. And it's again, like I said, I'm really excited to be here. This is a space that, I'm really passionate about. And as I mentioned, like this past week, presenting with, Caroline Apovian and John Jakecic was, for me, I was number 3 too. So the pressure was on, but
Oh, wow.
yeah, no, it was a lovely, it was a really lovely session. And I say lovely because, this topic is in some ways in the exercise world been a little bit controversial. And my background coming from being an exercise physiologist, working, out in the field for several years, medical fitness type space, and, working with a lot of patients with obesity over the years, feeling like I didn't know enough is what drove me to my PhD and to get, behavioral training in specifically obesity, exercise, and that relationship with, strong behavior change. So for me, it's like my career has shifted and been so focused on obesity treatment that in this new age, when these dynamic conversations come up where I feel like it gets split in half sometimes, it's a little hard. I think we saw a little bit of that with bariatric surgery in the exercise world as well too, way back when, folks like, you don't need that surgery. You can just exercise the weight away, and the stigma and all the horrible things around that.
Oh, yeah.
But yeah, but some of that came out with these medications as well. I would scroll through LinkedIn or social media, or people would message me and say, I cannot believe you're studying these. How could you? And it's like, how could I? This is about, treatment and humans and everyone getting access to all treatments, and that all treatments are really valuable. So these types of sessions, you walk into them, especially at the American College of Sports Medicine, with and ready for any kind of question. But I do need to give ACSM credit because they have been very open-minded to this topic and have had us at the ACSM Health and Fitness Summit earlier in February, giving us a similar talk with John Jakecic and I, but also Dr. Bob Kushner was at that session with us, which is great. It was in Chicago. And then to have this at the annual meeting, which is their seminal event every year, and just been willing to, support blog posts and different things so that we're really getting good education out there to our fitness professionals that are the boots on the ground, but also to researchers that are, looking at physical activity and metabolic health specifically. So it was a huge opportunity, and we had great interaction. So I'm coming out on a high, but also coming out with a lot of great thoughts and questions, to continue going forward with. So it was pretty great overall. But I'm, as I look at some of what we went through, I think, I could give you a couple highlight points from each of our talks, just as an overall, if that works. But, Caroline, Dr. Apovian she was amazing at really highlighting that, lifestyle is still a cornerstone and a foundation to all obesity treatment, not just medications. In just really having that understanding that it's important to continue to promote physical activity and, key changes in, the diet and other factors as it goes with this. So it was really wonderful to hear from someone who is an expert in the medical management of obesity to be able to come out and be very direct about that. And I think that was really a great model for exercise professionals and researchers to see that might have come in a little bit like, what is this about? And what are you all going to talk about, in that front? So she was very good. And she went through and talked about, again, medical management in general with medications, efficacy, and new agents that are in the pipeline. So she really started us out strong that way. And then John Jakecic, who is, if you don't know John very well, he's really truly one of the experts in the role of physical activity and exercise for obesity treatment. So has had numerous lifestyle clinical trials around the role of exercise, has been responsible for the clinical guidelines currently. I shouldn't say responsible, for contributed heavily to the clinical guidelines around how the dose of exercise with lifestyle, and has worked in, lifestyle and bariatric surgery projects as well. So thrilled to be working with him on this new endeavor going forward. But he really talked a lot about body composition and the role that exercise may or may not play, and really filled in some of the great gaps on, what we know and what we don't know. And I feel like a broken record, if anyone has seen me or things that I post, and saying that there's still a lot to learn on this topic. And John did a really nice job of, breaking down that everyone's talking about losing muscle mass, and that in a, hypocaloric state during weight loss, probably we're still learning what that actual magnitude of loss is and what real effect it has on not just physical function, but strength, mobility and all those things, which we don't expect to actually improve without exercise. And he looked back at some of the early, very low calorie study diets that included exercise or didn't, and the changes in strength and physical function. So really, really good stuff. And he also told everyone, announced that ACSM has a new consensus paper on obesity treatment that's going to be coming out here very soon. Yeah, it's great. And it Dr. Apovian's actually on it. Dr. Anita Corcolis, bariatric surgeon's a part of the paper as well too. So really highlighting some of the great things that are coming out of that and what comprehensive care and treatment should likely look like. So,
oh, good. I mean, I feel like that's such a need. These, everybody with their opinions right now makes it so hard to know, everybody's sharing what they're seeing in their practice. And there's just so much that I think needs that expert consensus and the evidence, which is, again, where I think, it's very interesting for me seeing what you guys are putting out, because again, in my space in body composition, I always say I feel lucky that we're not, one of the medication or the pharmaceutical companies, because what we're promoting is really, we don't know which is the best. We don't know which one, what percentage is the right cutoff or any of that. What we're really wanting folks to do is just integrate measurement and assessment into their practice, so that you can take, what the latest evidence says, but really individualize that to the person and take what their numbers are saying about their own situation and help them, improve or, get better in their way. So I love hearing what you guys are, talking about in this area.
Yeah. And I mean, and to that exact point, when we think about body composition changes, and I'll reference back to the very low calorie, studies. And what's fascinating, and it's not fascinating, I guess it's almost like what's old is new again in some ways when it comes to the exercise physiology behind this. But, without a shadow of a doubt, folks lose lean mass in this state, right? The magnitude may vary, right? Mm-hmm. And the one thing in these early studies, and I will say, like, they weren't measuring MRI to get it exactly muscle, or, using sophisticated measures like of BIA now that you all have. And they weren't doing those things, but it was this wonderful paradigm of whenever you had a resistance training component involved, you didn't necessarily attenuate lean mass loss. But what you did do in some cases is you did improve function, you did improve strength. Mm-hmm. And the same thing went for cardiorespiratory fitness. If someone was doing aerobic exercise, you saw those improvements in fitness. So now, will those models look the same? Things are more sophisticated now. We can measure more things, to your point. So I think that it's really, really important that we continue to do that. And we continue to do it in the research with all the right measures, all the way from, you and I have talked about many times, like DEXA may be the gold standard in research, but not in clinical practice, right? It's not necessarily feasible. So how are we making sure that we're doing the right comparisons so that in clinical practice, in our maybe fitness centers, right, we're getting the right data and we're using it the right way for the person and their specific goals, not just overlay a program. I think, and you know, we've talked about this before, is one of my biggest pet peeves in the exercise space is I'm seeing a lot of folks jump on this bandwagon of everybody needs the resistance train and everybody needs to get into the gym. And if you're on a GLP-1 medication, come to my gym. I have the perfect method or program for you. And I know I say that, you know, in a little bit of a, you know, a hyperbolic way, but I say it that way because for me, I take the breath. It really is about the human. And I feel that approach is not about the human. That's method centered, not human centered. And it really gets to the crux of what my talk was about at ACSM is while we may be learning these things, and I say we're learning them, we're learning exactly what's happening to body composition. We're doing some of that research at the University of Kansas Medical Center right now. I have a pilot project that's all about body composition and the biology of it, which I love. But we're also talking to, you know, patients at the same time and saying, how do you feel about exercise? You know, what has your experience has been? Because I genuinely feel like we need to be taking the biological learnings as they're happening, which it takes time, we know from the research, but talking to our patients at the same time so that when we do start to make recommendations, we're really putting the person in the center of them, not just overlaying a method or assuming that resistance training is the best thing. And, you know, that piece of it's near and dear to my heart. I can't get past that, right? Is I love the biology
you
of the
need to
behavior.
stay on that soapbox about that because that's so, you know, I feel like that's so what we're seeing right now is, you know, you've been in this field a long time too. It's like we finally have conversation, media attention, the masses interested, right? It's not this niche area that people think of as an other. It's always been affecting a majority, right?
Yeah.
But now people are paying attention to it. And what I don't love is people taking what I would call almost like taking advantage of that by, you know, business driven models that are really just aimed at, I think your words are perfect, method centered. You know, here's the program, get on it, right? And what we know is, I don't know that they all can really understand the long chronic nature of obesity and that this is a lifelong thing. So it's not just one little thing you're going to prescribe to them. It's how are you going to take care of this person in their culture and environment forever, because, you know, they're going to be a patient or a person interacting in this world forever.
And I love how you said forever with that, because, you know, as I've grown to learn and as I think the field of obesity has grown to learn, this is complex. And, you know, Dr. Apovian and Jakecic and I, you know, published a paper in the Translational Journal of the American College of Sports Medicine where we tried to draw a figure that was like, so when someone goes down an obesity, you know, treatment pathway, it could be lifestyle, it could be, you know, medication, it could be bariatric surgery. We kind of have them separated. And then I presented at the meeting as like, but that's not really how it is. This one's talking to this one. Somebody starts on this path. They go to this path. Maybe they have bariatric surgery. Now they're adding a medication. Those that have lifestyle incorporated seem to do better. All the different things, right, that go into it and the complexity of it, and that it's not one size fits all. And it is forever kind of treatment. It doesn't necessarily mean one thing maybe forever, right? Some recommendations are that right now. But when you see people saying, I have a GLP-1 program and it's 8 weeks long, you sit there and go, that. What is that? You know, like at the end of the day, like, and I also recently wrote in a article that's going to be published with the Idea Health and Fitness Association coming up here in June, which is mostly for exercise professionals in the space and owners and operators. Just this idea that I'm personally torn because it's exciting for me to see the fitness profession kind of get excited about something and not push it to the side and say, don't do that, right? But get excited. But then I'm like, but you're jumping the gun, knowing you're making a lot of assumptions when we don't really know the exercise impact. We can model it based upon what I described before, but we don't really know So all of a sudden, claims of attenuating muscle mass loss and all of these things are what comes out of the forefront in the marketing. And then to your point, really though, we can talk about muscle health. We can talk about function. We do know those things come with physical activity and exercise, but it's being marketed in this bubble of something, like you said, it's about a method, a money, a business rather than the human. We're pulling away. And my fear is that we are going to bridge the gap further between medicine and fitness rather than, it's going to get wider rather than get closer.
Mm. Yeah, and I mean, you really have to think about the person trying to navigate this space as a patient.
Yeah.
It's so difficult on so many levels, from knowing, who are the right people that have their best interests at heart, to, where to get even the right medication, and this whole, that's a whole nother kind of story. And then really just piecing together, if you don't land in a real comprehensive program that was designed that way, how do you piece this together for yourself so that you know that you're getting the support that you need when you may be getting a medication from a medication only kind of a pathway, and you're like, but I know I need nutrition, I know I need behavior, I
Yeah.
certainly know I need an exercise help. I think that's really complicated, and there's definitely going to be lots of different ways to piece that together, but I know that that's really hard for people to
Yeah.
do given how good they are at marketing.
Yeah, for sure. For sure. You battle that speed of being able to write a really good marketing post or social media post, right? Or get something out the door versus the speed of research, right? And the speed of really assessing, it's like layer one's researching, and then actually researching it in practice is layer two. They don't coincide, the speed of things, right? In the way you need them. So, I think as clinicians say, hey, get out there and exercise. There's nothing wrong with that. But I think how we frame right now physical activity and exercise, and we should probably be careful about the conversations and how we say it, right? I love the term muscle health. Your muscle health is important, your function and your mobility and your strength, and as your body's changing, right? Years ago, working in bariatric surgery, I remember patients saying to me, like, I am in a different body. I don't know my body. I step off of a curve. I don't know where I'm at. That kinesthetic awareness that we experience, like, those are good reasons to exercise, to feel like you know your body and feel empowered and strong and functioning and feeling your very best. I think as we talk to patients about the importance of physical activity, that's what we can say definitively. We know, we have evidence on, while we're working out the other stuff,
Yeah. And really getting people comfortable in that space. I mean, there's so much more, there's so many different ways, every year I think we get new methods for how to do that, but it's still, I would imagine, a pretty big divide between what recommendations are and what people are actually doing. And I
Oh
think
yeah.
that's where, your experience too in the behavioral application is so important. So again, it's not advice giving and top down driven, like, here's what to do, right? You have plenty of people out there willing to tell people what they should be doing, and it's so much more difficult to actually figure out how to help that person do it consistently long term,
Oh yeah.
change it up when they need to.
Absolutely. And, I'm so glad you mentioned that, because I think so many of our colleagues, in clinics are, and again, obesity to treat is complex. It's not easy. So there's so many things often to discuss that it's like, okay, and by the way, it's really important that you start exercising. And like, wow, that intention is really good. Or saying, hey, 150 minutes per week is the guideline. And this, when we look at some of the qualitative data I have from patients, and at KUMC, we do have a comprehensive weight management clinic, ABOM, certified providers, and we have dietitians on staff. They're talking about exercise. I know these things, and when we surveyed patients on anti-obesity medications, or I should say obesity medications is what we're moving towards now, what we saw is that only about 33% of them were meeting the 150 minutes per week recommendation. So even in situations where you're promoting it, it doesn't mean that it's leading to changing the behavior, engaging in the behavior the way that we hope. And, that got me intrigued when I saw that first number. I went, oh, but at the same time, it was like, okay, now we have more work to do. Let's understand why. Because I do think there's an assumption out there sometimes too that, once you start losing weight, that you will start exercising. And I think we've known that for years. Like any other health behavior, that's not
Right.
necessarily the case. Diet, whatever you want to say, without the right coaching, to your point, before. But I was lucky enough to do a bunch of qualitative interviews, like one-on-ones with a subset of our patients from a recent survey, and just say, like, you said this about physical activity. Tell me a little bit about your history. And wow, so much interesting information came out of it related to, self-efficacy issues of, previous experiences really getting in the way. And, I had folks talk about experiences all the way back to high school, right? Like I wasn't
Yeah.
chosen in gym class or sports teams or feeling, uncomfortable with my body weight, or struggling then. And lots of things historically in their past. But then I had people, shockingly enough, say to me, and it wasn't just one, unfortunately, say, now that I've been on these medications, now that I've started to lose some weight, I felt like I've had some space for physical activity, which is
Mm.
really exciting and positive. But they also indicated that they had gone to a gym, opened up to a trainer about being on a medication and being told, you don't need that. I have the perfect method that'll work for
Mhm.
you. So current experiences and we have to remember, right, what is out there in the media, the things that we're saying, those our own personal intellectual biases, as Ted Kyle puts it so well, of what we think work for someone. We have to remember that's not person centered. That's not helping the human that's in front of you. So much of what I learned in having these conversations with patients are that some are very new to exercise. They're not sure. So when they talk to their clinician and they say, get out there, go to the gym, do these things, all these fears and anxiety come in, right? Because it's not something that they know
Mhm.
and they need the support. Versus, I've had patients that I've talked to say, been there, done that. I've done every workout program. That's why I'm on these medications now, because exercise didn't help me lose weight or maintain my weight loss the way that I had hoped it would. So now we've got this new group of folks that are questioning the value of physical activity on their weight management journey. And that's a new challenge for us to think about. But we need to acknowledge and say, hey, it's not about energy expenditure anymore. This is where the person centered is important. We now need to demonstrate to those folks that, what do you need? How can I make you feel better? And how can I make physical activity serve you, not you fall into what you think physical activity needs to look like on a daily basis?
Oh, that's perfectly worded. And I feel the same way in nutrition, where it's, kind of that same version of that conversation with food and eating. And I think one of the things we're battling in this space right now is sort of the assessment that, well, the medication is going to do the weight loss, and that the other components, even studies that we hear that, the lifestyle component might not be as critical in the weight loss component, which
Right.
again is why I think moving away from having that be the focus and saying you're not doing it for that. You're doing it for all these other benefits, the function, the strength, the endurance, the flexibility, all of those things are going to be the components for doing
Yeah.
this. And the same thing with nutrition. You're not eating a certain way just to lose weight. You're eating a certain way to feel a certain way. And
Yeah.
you've got to ask those right questions to get into the person and their values. Otherwise, it's just a copy and paste thing that nobody will follow. That's not new.
No,
We've done this long enough to know that doesn't work.
it's so true. You're spot on about it. Because even talking about things like strength and flexibility, I mean, some people go like, I'm doing fine. Like, why does that matter? And then you really do have to talk deeper into, how can you are you really feeling your best every day? Are you waking up strong? Are you, like, standing your posture? All of these things functioning, picking up your kids and your grandkids, getting into that intrinsic piece of health and well-being that's much deeper than, we measure to learn and understand, but it's bringing the measurement and the data to life that we get and connecting it to the human is what makes the human move in the right direction. It's what how I've always believed we should go about it.
That's perfectly worded. I mean, I think that is the essence of this in a nutshell, is that, and again, when you've done this for a long time, we know gosh, wouldn't it be great if all of these things that we're seeing did work just because? Or, for me, layering behavior counseling on top of nutrition or exercise is so important because, again, it's so frustrating to see people get out there and tell people just what to do and, prescribe their regimen that worked for me, to a person, and you're like, but why isn't that working for this person? Yeah. And a lot on intrinsic motivation but the intrinsic motivation comes from an individual conversation, and that is also difficult because we don't have enough of the obesity care providers that people need to meet the need.
Yeah.
Right.
Yeah.
And so scaling some of, scaling some of these programs, figuring out how to reach people who might need less intensive counseling, education, all of that, and then who might need more and more of that comprehensive service. I think we do have a lot to learn to scale some of the stuff that we've seen work to the amount of people that need it.
And what we do in our clinical trials is not, real world feasible. Unfortunately, we know that, right? We're having to do things from a fidelity standpoint, or having to adapt in a certain way to get, patients to remain in trials. And it is very different from what we do see in the real world. It's funny probably how much of it doesn't follow. And I think you can appreciate from the behavioral standpoint is, while you love people talking about behavioral theory and the importance of it, overlaying a theory on someone doesn't work either. It's the same thing like overlaying an exercise program, right? A method on someone. It's really on a day-to-day basis, having the right conversations with the human to understand where are they at today? How do they feel? For example, with the medications, there's the biological side effects that come into play and how those impact what they can do on a daily basis, and you really finding relevant targets and matching and accommodating and adjusting. That's the beauty of really helping someone and finding that matching point. And you're exactly right. It's hard. There's not enough providers. There's not enough time. There's not enough tools. So I think a really big passion space of mine is trying to at least educate our fitness professionals on thinking about it through the lens of obesity treatment, not just as an exercise physiologist or what we know in the space, and getting an understanding of patient experiences and helping them to become better obesity treatment allies, patient allies in the space, so that they're embracing people as they walk in the door. To your point, they're asking the right questions. They're finding out what's relevant to the human. And actually, exercise professionals are really good at learning all the different ways that exercise is medicine and tailoring things. I think we've just in some ways gotten caught up on trying to be too specific sometimes for conditions, that we've lost the human element in the center of it. So hopefully we can keep learning and doing good work and having conversations like this and getting it out. And I think the flip goes for our obesity specialists and our providers to help them understand how can you ask the right questions of your patients and refer them to the right folks, when they don't have the bandwidth or the time, or the barriers are real. And with the patient load, right, that's now happening is, right, dream world is we create a network of fitness professionals trained and, specialized with the certificate in obesity care, and then have that network connection between. Maybe that'll be my my goal by the end of my career. We'll see.
Yeah, well, and so I know you mentioned too, there were some good questions from this audience. Obviously it sounds like it was well received. I love that they're, forward on programming and putting this to that audience. Is there any, what are some of these other unanswered questions, or where we need to go from here?
Yeah, I think a big area, some of the gaps right now are exercise tolerance. I think that, when we talk about things like building muscle or resistance training and programming and a lot of people that are experts in strength and conditioning work, and I will speak to it as well, about the importance of overloading the system or making people continue to work hard with their workouts so that they do get the gains or the different strength benefits. And that's with anything in exercise. But my big question is, going back to tolerance, is we haven't really done the studies yet to understand how a patient taking one of these newer agents, I think there's a little bit of work done on liraglutide, but they didn't really report on tolerance of the exercise or the dose. How do they feel? They're having side effects. Can they do the same amount of work on an injection day versus a non-injection day? How do you titrate it? Should we be recommending long bouts, short bouts? All those kinds of things I think are a nuanced area. I've had some really good questions about that. What we're researching, as I mentioned right now, is understanding, body composition quantity changes, right? What's the quantity of change, but also trying to correlate that with measures of quality without doing muscle biopsies yet. That's our next layer. But really getting at the strength, the function that we talked about. But, how do we deliver these programs? Is it really resistance training? Does it have to look and feel that way? Can we still get the health and the muscle health benefits from mixed training, combined training? And also the impact on not just what changes while you're taking the med, but what if you come off? What is the relationship? What about regain cycles? How about responders, non-responders, right? There's so much there. Not everyone responds with 15% with semaglutide and 20% with tirzepatide. There's variability in those responses, and what role does lifestyle, specifically exercise, play? So much to learn, and such an exciting space.
Yeah, well, it sounds like I'm going to have to keep up with some of these new resources that you mentioned that are coming out soon, and make sure that our listeners and everybody has access to that. And I really think we are in such an exciting time with so many new kind of pathways and ways to get to some better outcomes for our humans that we're really all serving together.
Yeah, I agree. It's a really, really exciting time.
Great. Well, hopefully I'll see you at one of these meetings coming up, and look forward to continuing the conversation. And thanks again for coming on here. And the best ways for folks to reach out or connect with you if they're interested.
Yeah, no, you can look me up through KUMC's website and reach out anytime through email. My email is publicly posted, but I'm also on LinkedIn, and I love connecting with people and learning through that community. I've met so many wonderful people. So you can just Renee J. Rogers, PhD on LinkedIn. So find me on there, but I'd love to keep, answer questions, be a resource for anyone. Feel free to reach out.
Great. Well, yeah, the conversation I think on LinkedIn about all of this has been really productive and a growth opportunity.
Yeah,
for
healthy.
better conversation. So
for sure.
Awesome. Well, thank you so much, Dr. Rogers. Happy to have you on here and talk to you soon.
Thanks again.